today because I have never taken care of cystic fibrosis patients. And I feel like you guys may not have either, given your residency and what we're exposed to. So just thinking about the future and where you're going to end up, you may come across patients that have cystic fibrosis. So let's figure out how to manage them. So we're going to thank Dr. Fernando for reviewing this lecture with me. So what we're going to go over today is we're going to start with a little just the basics, going back to med school, inheritance, genetics, how we go about the diagnosis now, and then kind of obtaining more of like a CF history, which we're maybe not so familiar with. And then we're going to go into the fun stuff. We'll do cases and we'll do different manifestations of CF, particularly pulmonary, sinus, GI, and pancreatic. So the reason this was so interesting to me is that a lot of times CF patients will present with a lot of symptomatology that we're so familiar with. So it's really important that maybe if this patient isn't already diagnosed with CF but is presenting with certain symptomatology, to kind of keep an eye on things, right? So we see a lot of things that look similar, right? We see constipation, we see vomiting, we see respiratory exacerbations. So things look really similar, but what I want you to do is have a keen eye and figure out what's different, right? So what's different in this picture, right? They all kind of look the same except for that one hanging off to the side there. So that's how I want you to think about CF. You may be the one to diagnose it, you may be the one to manage it, but you really have to have a keen eye. That's Piper, by the way, just 10 weeks old. All right, so how is it inherited? It's an autosomal recessive disease. About 1 in 25 people can actually be carriers of the defective gene. And as you can see here, between white of Northern European origin, Hispanic, African American, Asian American, I mean, our population, 1 in 16,000 of African Americans, so the chances of you seeing it here in Brooklyn is very, very little. But with the white population, Caucasian, 1 in 3,000, that's pretty high. So just something to think of in depending on where you would train versus where you end up in practice. All right, so just going back to the basics, and we're going to kind of fly through this because it's kind of in the back of your brain. It's the CF transmembrane conductance regulator, so CFTR. There's about 1,500 different mutations that have been identified, and it has to do with chloride ion transport, and that's abnormal, right? So when we can't transport these chloride ions, it tends to affect our secretion. So they're going to be thick, they're going to be more viscous, and it's not just secretions in one organ, it can be in multiple organs, particularly lungs, pancreas, intestine, and liver, and that's where you're going to see a lot of these manifestations. So there's 2 different types. There's either classic or typical CF, and that's going to be the most common. About 80 to 90% of your patients who have CF will have this type. This is a fully non-functional CFTR, which means that it affects multiple organ systems. As opposed to the non-classical or atypical, that's actually just a decrease in the protein function, but you don't completely lose the gene. Most of the time you'll see patients with episodes of pancreatitis and sinusitis, as those are the mostly affected organs in this type. So how do we diagnose it? We've all heard of newborn screening. So how does that ultimately work? It's really done in places where CF is more common, and what it detects is actually a pancreatic enzyme called IRT, which is immunoreactive trypsinogen. So this enzyme is released into the blood when the pancreas is damaged. So what the newborn screen is actually testing for is that IRT level. So if that's high, that'll trigger your newborn screen. And these are babies that would then go on to get what's called a sweat test. And that's really just looking at like skin chloride. Because again, it can't kind of come back into the cells, so it stays on the skin. Sometimes you'll even, like the classic board question is the mom's like kissing the baby and it's like, my baby tastes salty. That's kind of like one of those buzzwords for things CF, okay? So what do we need to know? We have a patient that says they have CF. What are the questions that we're going to ask above and beyond our normal history? So these patients are generally on antibiotics baseline, okay, because they have a lot of colonization going on. They tend to be on mucolytics, bronchodilators, so any nebulized medications. They're definitely on enzyme supplements and vitamin supplements. And that just goes into kind of the pathophys about how they can't, they don't have the enzymes to break down the food products that they eat, and they can't mobilize a lot of these essential vitamins. What therapies are they on? So this little kid is on what's called a chest vest or a chest physiotherapy vest. And it basically, you strap it on almost like a life jacket, and it's attached to some tubing and a machine, and it actually shakes them. In pediatric residency, we always knew when the kids were on chest vests, because they'd be like, ah, because they would always like love to sing because their voice would echo while they were getting their chest vest. So it basically shakes them up, and it loosens a lot of mucus and helps them expectorate it. So these are good questions to ask, like, is he getting a chest vest therapy at home? They may say, oh no, he broke a month ago, and that's why he's here with a respiratory exacerbation, right? Asking about any supplemental oxygen, you know, if they're kind of like an older CF patient whose lungs are kind of biting the dust, they may be on some supplemental oxygen. And then talking about recent hospitalizations, recent illnesses, coming to the conclusion of maybe this person is colonized with something in particular, maybe they have a resistant organism. Now, a lot of kids with CF are going to be followed in the CF center, but we don't always have those. Say they're traveling, who knows. They usually are followed by a pulmonologist who's managing their CF. So these are kind of going to be discussions when getting this history based on the parent or the caretaker, maybe in conjunction with their specialist. So they may know better about culture results and what their last antibiotic course was. But these are all things to ask and to kind of poke into a little more. And then surgeries. So is it someone who has sinus issues? Have they had any sinus surgeries? Have they had bowel surgeries? Removal of nasal polyps. Some kids are even at the point where they're getting lung transplants, bowel transplants. So like keeping those in mind that we wouldn't normally think to ask for in a normal pediatric patient. All right, so just going back to the antibiotics, right, this is just kind of the organisms that are ideally going to be targeted. So Staph aureus, H. flu, Pseudomonas, Burkholderia. These may be baseline antibiotics that your patient could be on, so don't be too thrown off if they're giving you quite a list, all right? And just so you know what they're aiming to cover in each one. We'll come back to this a little more when we talk about pulmonary exacerbations. So let's start with a case. So we have a 5-year-old female. She comes to the ER. She's got 4 days of fever, some fatigue, and cough. Her mom says she has asthma, which she usually takes an inhaled steroid and as-needed albuterol. She's been treated twice in the past few years for sinusitis by her primary doctor. On exam, she's febrile, she's tired appearing, she's kind of thin appearing, she's got some purulent nasal discharge, her sinuses are mildly tender, and she's got wheezing bilaterally. And then you go on to your physical exam and you see stuff like this. What do you guys think of anything? Throw them out to me. What do you see in these pictures? Clubbing, right? So just digital clubbing. What else? Nasal polyps. So what do we think this kid probably has that no one's ever told her she has? CF. Whoa, yeah, no surprise. Okay, so these are like classic CF findings, right? Digital clubbing, failure to thrive, recurrent sinusitis, sometimes nasal polyps, and maybe this history of reactive airway. So they leads, right? This could be a classic CF that just kind of got missed, or maybe she's more of an atypical picture. Okay, so this is where you kind of have to be a detective. When you see these things that they don't fit the picture that we usually see, which is the wheezer with the URI, get a little deeper and dive into that. So on our differential for this child, you know, you're kind of thinking head and chest, what's going on? So definitely sinusitis is going to be on your differential. She's got existing nasal polyps, so that could be complicating things. In her chest, she could have bronchiectasis, atelectasis, or new consolidation. So if you got a chest x-ray, you'd see this. So what do we think these little arrows are pointing to? Any idea? Okay, this is pointing to bronchiectasis, right? So what is bronchiectasis? It's basically thickening that goes on in the wall due to underlying inflammation, increasing mucus production, especially thick viscous mucus that's going on in these CF patients. And on the far side there, you can see that's kind of like a lung specimen where you can see how incredibly dilated and thin-walled these bronchioles get. So that, going back to that picture, that's your mucus plugging. That's an evidence of bronchiectasis in these patients. So pulmonary manifestations are going to be the most common ER kind of complaint that you're going to get. Every CF patient is going to have lung involvement for the most part. Most kids are going to get respiratory manifestations in the first year of life. About 75% of them will have some type of respiratory complaint. And these could be in kids that are just getting like recurrent bronchitis, recurrent bronchiolitis. But the problem is a lot of the early irreversible damage occurs when they're much younger, so in these toddler age groups. So that's why we kind of have to be on the alert if this kid just doesn't fit your normal reactive airway picture. And actually pulmonary failure, so the lungs themselves account for about 95% of deaths in patients with CF. So when we talk about a basic CF exacerbation, it usually has to do with the lungs. It is our most common cause of ER visits. These are going to present with kind of a variety of symptoms, things that we see every day, but in the CF patient, you have to take them very seriously because this is one of their leading causes of morbidity and mortality. So they're going to have increased cough, they may have tachypnea, dyspnea, they may have crackles on exam, their oxygen saturation may be dropping. The quality and the quantity of their sputum are questions you definitely need to ask in your history. These are usually due to, again, their baseline organisms, Staph aureus, H. flu, and Pseudomonas. And knowing a little bit about their colonization history will be helpful in terms of prior sputum cultures. These kids most likely come with fever, though they don't always have to. A lot of times a chest x-ray is going to be pretty diagnostic for you. You don't have to go right into a chest CT unless there's something abnormal in the presentation. You can kind of break it down by using this Feeks criteria. I thought this was interesting. I didn't think it was anything mind-blowing. You have to have 4 of 12 of these following signs or symptoms in order to be considered a respiratory exacerbation. So, like we said, changes in the sputum, new or increased hemoptysis, cough, dyspnea, fatigue, fever, anorexia, sinus pain, sinus discharge, change in your physical exam of the chest, right? So you have more crackles or knees. So, okay, that's nice. If you have radiographic changes, then you're more concerned about advancing disease, consolidation, things like that. But it's something nice to at least kind of look at and stratify your patient. So how do we go about treating this? If it's mild, right, so your vital signs are stable, the child is not in extremis or extreme respiratory distress, you can probably add an oral or inhaled antibiotic, okay? You can continue with airway clearance and probably be a little more aggressive with bronchodilators. And again, a lot of this management is going to be a little bit in conjunction with their specialists, right? I wouldn't go going rogue and like starting your own kind of pathway here, but I would kind of do this in consultation. If they're moderate to severe, they're going to be hospitalized. And again, this comes naturally to you guys, ABCs, right? So if a kid's not breathing good, we're going to support their breathing, whether that's intubation, BiPAP, whatever. Definitely administering IV antibiotics with broad coverage, and I'll go into that. Continuing bronchodilators, adding on steroids to help with this part of the underlying inflammatory process that's kind of flaring up, and making sure that they have really good nutritional support. That may not be something so focused in the ER, but definitely while they're inpatient, making sure they get good nutrition. And again, kind of following up these airway cultures, secretion cultures, to see what they've been covered for in the past. So this is kind of a similar picture to what I showed you earlier, but it's actually just a step up, like what would you do to increase your coverage for certain organisms that you're concerned about. So again, your Staph aureus or MRSA, Pseudomonas, Burkholderia, and then the other kind of funny ones, right? That maybe are not going to be in your normal kiddo, but would be in a CF patient. So, you know, starting things like meropenem, Cipro, those would be something indicated in these patients. All right, let's move along to our second case. This is a 10-year-old male who comes to the ER with 3 days of progressive eyelid swelling. He's had some rhinorrhea and cough. He now complains of some blurry vision in the right eye and pain on eye movement. Vital signs are normal, except he's febrile to 101. His mom sees he's otherwise healthy. He's always been a small child for his age, and he occasionally gets sinus infections treated by his P&D. On exam, you know, swelling to the upper and lower right eyelids with proptosis. He's got normal conjunctiva. Pupils are equal, but extraocular movements are painful, with tenderness to palpation over the sinuses. Ugh. What do you guys think of that? What do you think? What's on your differential, just thinking of that? Sinusitis, maybe? Okay. So what do you want to do for him? Pictures? CT scan, sure. Okay, that's what it looks like. Ugh. What do you think of that? It's got something right about there. Okay. So that's pretty impressive, right? We don't see that every day. Does anyone know what this is called? Mucocele, absolutely. Yay, good. Okay, it's called a mucocele or a mucopyoceal, right? If it's really, really curly. This is basically a complication of sinusitis. What ends up happening is you have a pacification of the sinus, which causes kind of bony expansion. Eventually that bony expansion is going to erode away at the bone, and it comes from a blockage, like where you just can't get these secretions out. So it expands only so much until the bone gets broken down, and then it starts to invade. So you can get some major complications from this. You can have orbital, right? So you can get like a subperiosteal abscess. You can have intracranial, whether it's an empyema, an abscess itself, even spreading to meningitis. You can also get sub-Q, like, you ever heard of Pott's puffy tumor? That's kind of a complication of the sinusitis that goes subcutaneous. So that's kind of something to think of in these kids. And basically, these kind of like thick, tenacious secretions really just obstruct that the sinus ostia, and you get increased edema, you get swelling, and it really has nowhere to go, and then you kind of get bacterial overload on top of that. So the big things to think about here are how we're going to treat it. So you definitely want to increase your antibiotic coverage of Pseudomonas and Staph aureus for sure. If this is a kid who's somewhat colonized by Candida, you want to start thinking of antifungal. If this is somewhat simple, which I don't think I would categorize that patient as, then you can do antibiotics, sinus irrigation, mucolytics, and steroids. But if it's more complex, you're definitely going to need to advance into more surgical intervention. And that's probably going to be with your ENT colleagues, I would think, to go in there and wash it out and fix things up. All right, so here's our other case. We're going to keep this moving. So a newborn arrives to the ER via EMS from home at 26 hours of life. Parents report the baby was born at home with the aid of a doula, as was their birth plan. They report the baby was full term, delivered vaginally, clear fluid, rupture of membrane was about 10 hours. They report the baby had been breastfeeding every 3 hours, but this evening they got concerned the baby had an episode of greenish emesis and didn't appear as active. They report no urine or stool passage in the last 8 hours. On exam, you find a tired appearing infant with dry skin, soft but protuberant abdomen, and she cries weakly on deep palpation. What's your differential for this baby? A little louder. Meconium ilis. What else? Sepsis, absolutely. Come on, give me a couple, two more. Duodenal atresia, sure. What about the other belly things? We talked about this at the last PEM conference. Malro, yeah. So volvulus, malro, sepsis, and meconium ilis, because this is the CF talk after all. So yeah, I think that's definitely a good broad differential that you won't really miss too much stuff in. And this is definitely important, right? So this is a baby that was born at home. It wasn't in the nursery. If you guys have done NICU nursery rotations, you know that like passage of meconium is the big thing, right? We've got to keep an eye on that. So this baby clearly hadn't passed any meconium. And it basically creates an obstruction of the small bowel, and you kind of get a dilatation of the bowel proximal to it. So actually 80% of cases of meconium ileus are due to CF, right? So if you have 10 babies in the nursery and 8 of them have meconium ileus, those 8 are very likely to have CF. Of CF patients, about 15% of them have had a history of meconium ileus. So that's also something to add on to our CF history when we take it. The obstruction tends to occur at the level of the terminal ileum, and you may actually see a bit of a microcolon that's going to be distal to that obstruction, and that's mostly due to disuse. A good imaging study for this would probably be an x-ray to get like a perf obstructive series. That'll give you a good idea of the bowel gas pattern. And obviously treatment of this is usually going to be a contrast enema, but may require surgical reduction or resection. Okay? All right, let's do another case. So this is a 3-year-old male who comes to the ER with abdominal pain. His parents report he's been crying in pain for the last 5 hours. There's been 1 episode of non-bloody, non-bilious emesis at home. He's been afebrile with no recent illnesses. Her mom, he has a history of infrequent stools, which are often bulky and foul-smelling. He occasionally needs an enema at home to aid in stooling. So on exam, you find an uncomfortable appearing toddler. He's crying, he's holding his knees to his chest. His abdomen appears soft but diffusely tender, and no masses are appreciated. What's your differential, guys? Give me like 4. A little louder.
Pancreatitis.
Okay.
Intussusception.
Intussusception, sure. Constipation. Those are the majority of them. So constipation, intussusception, appendicitis, bowel obstruction, right? These can all be kind of challenging to differentiate from one another in this just crying toddler. So what I want you to do is kind of go back to your history, go back to the fact that, you know, he's had constipation in the past. He has these bulky, foul-smelling stools, right? That's going to not be your normal poop history for a kid for the most part. So those are things you want to investigate, like maybe this kid has an underlying cystic fibrosis. So that's kind of what I want you to think of. Where does one start and one end and another one begin? Okay, that's going to be your goal as a practitioner. All right, so constipation, where do we deal with it on a daily basis? But in kids with CF, this is going to be particularly important because they usually have a baseline constipation going on. And that's really just due to these inspissated, which means thick secretions. They can't really, they don't have digestive enzymes, so they can't break their stuff down. And they get malabsorption, so they don't get those fat-soluble vitamins, A, D, E, and K, that most kids will be able to break down. And they tend to have these, almost like a steatorrhea, like a fatty, kind of foul-smelling and very, very bulky stools. So this is your classic picture of constipation. You can see it all throughout the colon. But these are kids that may need to be on work maintenance therapy and can ultimately lead to other further problems down the road, which I'm going to address a little further. And what if you roll this kid over and you see that? Ugh, right? Not fun, but common, okay? So rectal prolapse, right? Kind of scary, but can be kind of common in kids. It's usually under the age of about 4. And a lot of times it comes from constipation, it's more functional. But it can also come from diarrheal illnesses, just kind of baseline getting a lot of inflammation in the intestines and having, profuse stooling. It can be a complication of malnutrition. This is seen in a lot of kids in like third world countries as well. And it can also be neurologic, right? So you have kind of some type of different innervation going on and you're not stooling normally and you can have prolapse. So actually CF accounts for about 11% of rectal prolapse in the entire Western world. And it may be the presenting sign that you see. And they have a number of about 33% of patients present with rectal prolapse before they have any other symptoms in CF. So if you're seeing rectal prolapse, dive deep into that history and figure out what's going on. I'm not going to go crazy into the management, but a lot of it is just gentle, firm pushing, okay? Just kind of push it back up a bit. But when you see it, think about it. This is a red flag to start asking more questions. So I know we said it before, intussusception, right? Something we're always thinking about, something we're getting really good at evaluating for at the bedside with ultrasound. So this kid would be a prime example of someone that I would evaluate for intussusception. Here you have a nice target sign with your ultrasound, and then you have obviously on your enema evidence of that intussusception. So intussusception actually is found in 20% of CF patients that are presenting with obstruction. And it tends to be ileocholic, and it really has to do with the fact that they have this really thick, tenacious fecal material that's going on in their intestine, as well as a lot of underlying inflammation that can create like lymphoid patches. So those can be actual lead points. So don't be surprised if your CF kid comes in with belly pain and has intussusception. He's very much at risk for it. And then another thing I found when I was reading about this is this concept of a chronically distended appendix. I was like, that's weird, we don't see that in any other kids. So what does that mean? When we think of appendicitis, the frequency in CF kids is actually lower than that of the general population, which I don't really understand why, but I thought it was kind of interesting because if I had a kid coming in with belly pain like this and I was evaluating for appendicitis and I saw something that looked like that on my bedside ultrasound, I'd be calling the surgeons. Oh, I have a kid with appendicitis here, right? Nice and dilated, not compressible. But what's next to it is actually impacted stool that's sitting in the CoOp. So it's kind of creating this little backlog, right? So some kids tend to have this mucus accumulation, creates a dilatation of the lumen, and actually their baseline appendix can be greater than 6 millimeters on a good day. All right? A lot of these kids, even if they did have some appendicitis, they're usually on antibiotics baseline that would kind of mask some of that inflammation, so you may not get that dramatic appendicitis picture. And these kids tend to come in with recurrent abdominal pain issues, whether it's from constipation or otherwise. So the concept of having a differential of appendicitis in the child with cystic fibrosis is something you definitely are going to have to look at every different detail. And in these cases, a lot of times imaging, perfect, you can get an ultrasound, but maybe even a CAT scan might be more helpful because you do want to see elements of maybe like fat stranding or kind of periappendiceal inflammation that would be a little more supportive towards an acute appendicitis, as well as getting some labs, okay, to see if what we're talking about is a true appendicitis or just a baseline enlarged appendix. So I thought that was a pretty neat picture. All right, and then here's another set of images, which was something I didn't know anything about in CF, but it's this phenomenon called distal intestinal obstruction syndrome. Has anyone heard of that? Maybe? No? Ideally, it's a kid that comes in with abdominal pain. You're concerned for obstruction. They may have even like a right lower quadrant mass kind of sitting in that ileocecal region, and it may even be palpable. And it's basically a bowel obstruction. And I thought this picture on the far side here with the arrow was kind of interesting because that's actually hyperdense, like fecal impaction. It's actually prolapsing from the terminal ileum into the CPAP because they're so backed up. All right. So how does this happen? It tends to be a combination of things: pancreatic insufficiency, thickened intestinal secretions with undigested food remnants, and baseline poor motility creates this impaction of this mucofeculent material in the distal ileum. This occurs in about 10 to 15% of cystic fibrosis patients, so it is fairly common. Dehydration can precipitate this. They may have some distension, vomiting, just like you would in a normal bowel obstruction. And actually, this is patients who had a meconium ileus as a child are actually at increased risk of this. So if that pops up in your history, definitely start going down this path. And the prevalence is actually highest in about 20 to 30-year-olds. So that's going to be patients that you guys are going to be seeing. So how do we manage it? If it's incomplete or partial, right, they may be able to orally rehydrate. If they're not persistently vomiting, you're really going to start stool softeners, so like a polyethylene glycol, 2 per kilo. And the goal is actually to take it in until everything's coming out clear. If they're completely obstructed, then you're going to go down your normal route, IV hydration. You're going to decompress with an NG tube. You can start NG polyethylene glycol, and you can actually consider a gastrographic enema because it actually, in essence, does a retrograde lavage. This is something that you would do under direct supervision with an experienced radiologist, kind of like you would do an enema for a intussusception. So that's an option. All right, here's our other case. We're getting to the end, guys. So 15-year-old female with known CF presents with spitting up blood for the last 2 days. She states it started as blood streaks in her sputum, but now it's grossly bloody every time she coughs. She denies any fever, vomiting, abdominal pain. Her exam's pretty benign. And what's on your differential for her?
Invasive
Bronchiectasis, invasive aspergillosis, love it. What else? Pulmonary hemorrhage, exactly. So this is a hard case because she's like, I don't know, I'm a teenager, blood is coming out. I'm not going to give you any more details. So you kind of have to think, like, where is it coming from, right? Is this respiratory or is this GI? So in CF patients, blood streaks are going to be very common, like Olu said. In cases of bronchiectasis, this is what you're going to see. But as we mentioned, you kind of can go down the path from just basic bronchiectasis to more of a pulmonary hemorrhage kind of picture. And then in the GI kind of category, these patients tend to have like a cirrhosis and a portal hypertension that can lead to varices. So you may be getting more of a GI kind of view. So these are things you kind of have to parse out. You may be able to get them more in your history. Is this kind of frothy? Does it seem like it's coming when you cough? Versus, if you're vomiting, things like that. If there's any history of melena, of course. So what's the role in hemoptysis here? Again, we have this baseline inflammation with infection on top of it. Our bronchial arteries tend to proliferate, and in that point they get hypertrophy. The venous communications tend to get enlarged, and that's going to increase blood flow and create this neovascularization. New little blood vessels start to form, but they're very thin-walled and tortuous. These thin-walled and tortuous vessels don't have a lot of holding capacity, and they do risk rupturing into the airway, and that can lead to your pulmonary hemorrhage. So how to manage this if it's scant, right? You're going to continue your maintenance therapies. You're going to continue your inhaled bronchodilators, your chest vest therapies, your mucolytics to kind of just help clear the secretions. If it's mild to moderate, you may want to consider adding antibiotics and admitting the patient if they're having a fair amount. But if it's severe and we're talking concern for pulmonary hemorrhage, this is when you're going to go into your CCT mindset, ABCs, IV blood products. There's been shown data for TXA. I would probably initiate antibiotics as well, just for coverage, because again, we know that the pathogenesis has to do with an underlying infection and bacterial overload. If the patient is stable, you can kind of go towards, this is a nice little flow chart here. If the patient's stable, you can do a CT scan to kind of further isolate what's going on. But if they're unstable, then they need bronchial artery embolization. So that's something to think about. And if you think this is more GI, again, ABCs, prepare to give fluids, transfuse as necessary. You can NG tube lavage if you think this is coming from the stomach or the esophageal varices that this patient may have. You can initiate octreotide as well as considering vitamin K, because again, these patients can be coagulopathic. They have A, D, E, and K, right, are their vitamins that they can't really make available to them unless they have the right enzymes. So think about that, and obviously you're going to consult GI if you think an endoscopy is necessary. Other things to go over that just to kind of keep in the back of your mind that we're not going to dive into today, but cholecystitis, cholelithiasis, A lot of patients, about a quarter of CF patients, are going to have asymptomatic cholelithiasis. That can easily be diagnosed. You guys do it all the time, looking at the gallbladder on bedside ultrasound. Pancreatitis is actually fairly uncommon in a classical CF patient because the pancreas is so inactive, right, that it doesn't really have that ability to flare. It's going to be more people that have the atypical or non-classical because they do have that residual exocrine activity that's going on, so they may be more candidates of pancreatitis. And then diabetes, because classic CF, about 40% of patients over the age of 35 are going to be the equivalent of like type 1 diabetics. So they can get all the same complications. They have no insulin on board, so they will need to be supplemented. They can have retinopathy, renal disease, as well as peripheral neuropathy. So keep that in the back of your mind when you're taking care of these patients as they get older, because now that we have more therapies, they're living longer. So you're going to see them into their 40s. All right, let's go over some take-home points. The basic things that I want you to get from this are considering CF in kids that have things that we see normally, but it's just not fitting the picture. So consider it in kids who are getting frequent respiratory infections. They're poor weight gain, they're almost like a failure to thrive picture. Kids who are having constipation, and like I said, rectal prolapse, that's a big thing I want you guys to think about. Pulmonary exacerbations, consider colonization in prior cultures when you're choosing your antibiotics. You can use Feeks criteria to kind of see where you stand in terms of moving forward on your diagnosis and management. Chronic sinus disease, as we saw, can progress into CNS as well as ophthalmologic complications, such as a mucocele. So getting that good history is important as well. And abdominal pathology is going to be the tricky one. It can be very complex to diagnose. A lot of times, based on what I've shown you here, I think we can decide that imaging is going to be kind of helpful, and using that plus maybe some laboratory values to help you think, is this an appendicitis, is this an infectious kind of process? And then last thing, hemoptysis leading to pulmonary hemorrhage can be a life-threatening complication of CF. And you should really have a high index of suspicion if you think this person is bleeding more pulmonary than GI. Anyone have questions? Yes?
Are these patients like asthma kids where like you're trying to do everything before you intubate? Like so when you fit the bad slam, or is it like so?
That's a good question. I don't think they'd be the type that you would avoid intubation. I mean, we already know that they start off with morphologically normal lungs, but they have all these secretions and inflammation going on that I think in order to keep them alive and protect them, I probably would intubate. I don't think it would be as much as looking at it like an asthmatic. It would probably be a little bit different, but I would probably intubate if I needed to. Any other questions? No. Okay, thanks guys.
All right, 5 minutes, everyone. 5-minute break.